just wanted to highlight that pediatric cataract and the surgeries, what are the challenges? Now, I'll just go fast because I think we have to vacate this room. We're already short 10 minutes beyond the time. So, when we had done a survey with Orbis, basically the major barriers which we found were access to services, economic difficulties, and beliefs that children were too young for surgery. Yeah, this all Raman has already covered, so I will not cover most of these things. But the main factor which I wanted to stress on was that there is a long way to go. We still need to treat and catch these children very, very early, and so this is a major challenge. The problem is now again Orbis is thinking of setting up secondary centers, but even the secondary centers, the main problem is GA facilities and how do we operate children early with pediatric cataract with the available GA facilities is still a major challenge. And this is what with organizations will have to work on how to arrange GA facilities when we are training the pediatric ophthalmologist with pediatric surgeries. So the other thing is the surgical technique. Now even in children, when I went for evaluation of many pediatric centers which Orbis has supported, what I found was they were still not doing PCC with anterior vitrectomy in children who were less than 6 years. They were just leaving them aphakic, or basically because they were just doing ketamine, and so they just wanted to make 2 small openings and remove the cataract. So that it is much safer and without any risk. So it is important that we have to train them that it is not just important to remove the cataract, but we have to also ensure that this visual axis is maintained clear even throughout life of the child. So this is what we need to train. Along with the pediatric cataract surgeon, we also need to give them equipments. Maybe they need a phaco machine, or maybe add a vitrectomy machine along with that phaco machine, because otherwise there is no point in treating children with cataract below the age of 6 years. So I'm not going to go the videos because there is no time for all this. Then the IOL, also the cost factor. Again, there is a lot of certain managements may allow you to put Acrosofts or the best lens in children who are less than 4 years. But most of these sectors, they tell us to put PMMA lenses in children, and it is seen that PMMA lenses, all literature, all published material in the world tells to put Acrosoft lenses or put single piece lenses in children who are younger than 2 years or younger than 4 years of age. But the practicality of the cost and whether we are able to put them is still a big issue. So even in our setup where we have the maximum support, we still find that only 27% of the children could put Acrosoft IOL. So the risk of PCO formation, then again the high rate of reactions, and even when you put PMA lenses in children less than 2 years, the glaucoma rate, all this will increase if we do not give this support to the organizations. Then the power to be calculated, the IOL power. Now how many centers would have a portable keratometer to do the IOL power calculation? Even after having a portable keratometer in these setups, we do find that that there is using the target refraction, which is ideal for children below the age of 9 years. We know that we have to calculate this and put this in children. We still find there is, in our study which we have done in our audit at Stroff, we still find there is so much of variability in the refraction. So even after the surgery, are we really treating the blindness? So we are still making the children a lot of variability in refractions. So we might get a +6 or +4 as surprises, and then we have to give them glasses, and are they really wearing the glasses? So this is what we find, that even with in our setup where we did an audit and we found that visual acuity was more than 618 only around 54.9% of children, and 618 to 660 was 22.1. So this is also are we really treating the children with blindness? Why? Because most of them are presenting late. So when you compare the visual acuity and visual outcome related to the age of treatment, we find that in less than 2 years we get a very good result, but how many are actually coming at less than 2 years? So this is most of them are coming after 7 years, and we are saying we are treating pediatric cataract, but most of them are turning out to be with low vision. So the complications, mainly PCO, it will depend on the type of IOL. So even we have to think of putting more and more of these very high cost IOLs in children. And the follow-up rate has, Dr. Rahul mentioned that do we have a real follow-up? Now it's important that we operate and then we leave, then after 2 to 3 years we find that they develop a posterior capsular opacification. How many are we actually following up? And again they become blind. So are we really following up to find out that these children have again become blind because of PCO, and are we taking care of it? So it is not only important that we just do them, but refractive correction, amblyopia therapy, PCO, low vision, all this is an important part and parcel of the pediatric cataract surgery. And then is the glasses, of affordability of the glasses. These glasses will change every 3 to 6 months. So how are we going to ensure that we get these children back and put in these glasses? And most of the time we operate children from far, they say that they are refractionists, cannot do pediatric refraction in such small babies. So now they are not able to give the proper glasses for the babies. So what are we actually treating? Are we just doing surgery and leaving the babies like this? And then the other problem is the glasses also, when they are very high refractive, whereas more than 20 diopters, we do not even have any company which is giving us in plastic these lenses, because in glass they are available, they are not available in plastic. So where do we get these glasses for these children? So actually there's a question mark of what are we treating actually. So we need to give them amblyopia therapy, then occlusion. So now we know the regime. All this is theoretical, but how do we treat like PCO formation? Are we going back on follow-up and treating the PCO? And then is the additional cost. So already the child, if you have left them aphakic, you've already done 4 surgeries, because you have done 2 eyes cataract, then you may have done a membranectomy, you have done a secondary IOL implantation in these children, again is a cost. And now the 5th surgery is when you develop again a PCO, then the parents have to again pay for a membranectomy. So ideally sometimes the surgeon says, okay, they don't even tell the parent that the PCO is formed. Nobody is checking them, so you leave it alone, and actually when the patient will come with strabismus. So the 6th or the 7th surgeries may be your strabismus surgery. So this is something which we with the NGOs have to really think when they are supporting, because all this is the cost for an actual pediatric surgery. It's not just the cost of one surgery. So this is what just basically, and I have just taken the count of pediatric cataract. Dr. Sunita is there, who does done pediatric glaucoma surgeries. She knows of the importance of the follow-up of these surgeries, and maybe we require multiple such surgeries. Then we have squint surgeries also, we have to have a follow-up. So the cost factor also should be taken into all these. Then we are doing surgeries in children.